Hello, my name is Gilles Salles. I am the service chief of lymphoma at Memorial Sloan Kettering from New York, and I'm happy to discuss with you today what do we currently know about EZH1 and EZH2 inhibitors in the care of patients with lymphoma, and what the future will be regarding the development of these drugs. So, as you have learned, the epigenetic is the way to control the expressions of genes within the nucleus, and they are targeted by many mutations, particularly in follicular lymphoma, but also diffuse large B cell, T cell lymphoma, and others. And these mutations are thought to be involved in the oncogenic process leading to lymphoma. On this slide, you see a couple of chromatin modifying genes that are a topic of mutation in patients with lymphoma, and what this mutation result in terms of gene expression, which mostly result in increasing cell survival, increasing cell proliferation, diminishing apoptosis, modifying the cell fate and B cell differentiation, and also have an impact on immune escape. If we focus on EZH2, EZH2 is an enzyme which is the enhancer of the ZES2 polycomb repressive complex 2, so PRC2 complex, and it has a very important role in germinal centers, as was identified by the group of Dr. Melnick. You can see here in the germinal center that when the B cell enters the germinal center, EZH2 control with PRC2 the methylation of an histone, which is called H3 at the position lysine 27, so H3Q27, and it trimethylates these histones. And this control the process and the navigation, I will say, differentiation of B cells within the germinal center. When there is a mutation of EZH2 that we observed sometimes in patients with follicular lymphoma, there is a gain in function mutation, there is an increase in the trimethylated form of this enzyme. And because of that, these cells will be maintained in the germinal center and will be further supported for their growth and malignant process, while there are also some effect on T cells. In this schema, we have represented the role of EZH2 in normal germinal center. EZH2, which is called enhancer of ZES2 polycomb repressive complex 2 or PRC2, is a key regulator of the transit and the differentiation of B cell within the germinal centers. As you can see here, this is a place where it plays at the entry of the germinal center when the cell navigates here, and part of this complex when they enter, and it's free here. And the key mechanism here is the methylation of this histone, which is the H3 histone, which is in monomethylated, bimethylated, or trimethylated form. This may look complex to you, but in fact, what is important to understand is that EZH2 in normal germinal centers, but also in malignant ones, play a key role in the navigation and differentiation of the B cell within the germinal center. What happens when EZH2 is mutated is that it shifts the methylation of H3 towards a trimethylated form, and that increase the capture and the maintenance of this germinal center B cell within the germinal centers and represent another advantage for this cell for the malignant process. In addition to that, there are other mechanisms such as decreasing the TFH role and increasing the FDC dependency of these B cells. So the percentage of follicular lymphoma that are mutated is about 20%. We do know that when the mutation is present at diagnosis, patients have a little bit more favorable prognosis. But when we observe patients that were treated at the time of relapse, what is shown here is that the outcome of patients with or without a mutation did not differ. Based on this rationale, there was a sense of targeting EZH2. Again, this is a methyltransferase in enzyme. It's relatively easy to target. It's required for normal B cell biology. And the mutation just emphasizes and augments the effect, but this effect is also present in follicular lymphoma without the mutation. So for this reason, we say that this biology is important both in mutant and unmutated EZH2 follicular lymphoma. So the drug that we'll discuss first is called tazemetostat, and it inhibits the function of this enzyme. In phase 1 data, which included patients with both B-cell lymphoma and a specific form of solid tumor that had abnormalities in the PRC2 SMARC4 complex, it was identified that, first of all, it's a drug that is well tolerated. Treatment emergent adverse events were only present in less than 5% of the patient. Secondly, the recommended phase 2 dose was determined to be 800 milligram twice daily, and there was a plateau of the methylation of the enzyme or demethylation of the enzyme with this dose. And there were some patients with follicular lymphoma, and as you can see, one patient had a complete response, one has a partial response, and this led to a more robust phase 2 to investigate the role of tazemetostat. This phase 2 comprised different cohort of patients, one cohort of patients who had a mutation in EZH2, and one cohort of patients which were wild type for EZH2. As you can see, there were no major differences, except that this patient with the wild type EZH2 were a little bit longer time in the disease, may have received a little bit more anti-cancer therapy, so were likely a little bit more severe. Again, more patients with refractory disease, double refractory, exposed to PI3 kinase or to transplant. So probably more difficult patients to treat the ones that were wild type. When we look at the response rate, and this is showing the best response as PR or CR, you can see that in the cohort of patients with mutated EZH2, which is represented here on the left, the overall response rate was 69%, and the complete response rate was 13%. In fact, the vast majority of patients had also stabilization of their disease. If we look on the right at the cohort of patients that were unmutated for EZH2, still the overall response rate was 35% and the CR rate was 4%. So some encouraging result even for this group of patients. What was further interesting is when we look at the duration of response or the progression-free survival of this patient. As you can see on this graph, there were no marked difference in the duration of response between patients that were mutated for EZH2 and those that were wild type for EZH2. And this is only in responding patients, but also if we look at progression-free survival, you see that the median progression-free survival of patients with mutated EZH2 was 13.8 months and 11.1 months in patients with wild type. So again, not a significant difference. So this is explained again by the role of EZH2 in the biology of B cell and in the biology of follicular lymphoma. What about the safety? The majority of patients, these were relapsed refractory patients, experienced some treatment emergent adverse event. But as you can see, only 4% of them had a serious TAE. Only 9% of the patients had a treatment emergent adverse event leading to dose reduction. About one quarter of the patient had the dose interruption, but finally, only 8% of them had to discontinue tazemetostat due to this event during the trial, and it was thought to be treatment-related, drug-related in only 5% of the patient. So overall, despite a difficult-to-treat population, few dose reduction, few dose interruptions, and very few dose discontinuation. If we look in detail at what were the adverse events observed in this patient, you can already see from this graph, and this represents both the wild type and mutant form, and there is no difference at all between these two groups, but that the majority of side effects were essentially of grade 1 and 2. There were very few grade 3 adverse events and virtually no grade 4 except some hematological toxicity. Again, patient experience may have experienced grade 1 to GI symptoms, nausea, diarrhea, cough, asthenia, fatigue, very few infections. And as you can see, these were 2 or 3% of grade 3 asthenia and fatigue. If we turn to hematological side effects, we were about 5% here in this group of anemia, thrombocytopenia, and neutropenia, which was mostly reversible, and again, less than 5% this group. So overall, less than 5% of grade 3-4 event, and an overall well-tolerated drug, no cardiac effects like we see with other targeted agents in lymphoid malignancies. So the conclusion of this study is that this drug, tazemetostat, is active in relapsed refractory follicular lymphoma in this trial. We saw a better response rate in patients with a mutation of EZH2, but the similar duration of response. Obviously, as I told you, the groups were different, and there were patients more severe in the wild type group, and the safety profile was favorable. This led, more than 4 years ago, to the accelerated approval of tazemetostat with an indication that is follicular lymphoma in patients with a mutation of EZH2 demonstrated by an FDA proof test having received at least 2 prior lines of therapy, but also other follicular lymphoma with unknown status of EZH2 for which there is no other satisfactory alternative treatment options. There have been a couple of trials assessing combination of tazemetostat with different drugs. One trial conducted in Europe was combining with rituximab CHOP, and the results were presented recently with some interesting response rate to be followed. There have been some in vitro data and ongoing trial regarding the combination of tazemetostat or venetoclax. But what is important to understand is that EZH2 plays a role in B cell, but plays also a role in T cell. And even in this function in B cells, it modulates the expression of some antigen and proteins that are important in immune regulation. And this is overall simplified in this scheme, but again, trafficking of T cell, infiltration of T cell recognition of tumor cells, killing of cancer cell, antigen presentation, priming, all of those could be influenced when you inhibit EZH2 inhibition, providing the rationale to combine tazemetostat with drugs that are acting in the immune response. And we constructed a trial, which is called Symphony, where we combined tazemetostat with lenalidomide and rituximab. This is a study that had 2 phases. One phase, which is the phase 1b phase, which has been fully conducted and already presented in meeting, where a non-randomized phase where tazemetostat was given at different dose level in combination with the R-square regimen. You are all familiar to the R-square regimen, the combination of rituximab, lenalidomide based on the augment schedule, a treatment of choice of relapsed follicular lymphoma. So in this phase 1b, we assess different doses of tazemetostat. The second phase that I will discuss later is a randomized portion of this study. As you can see on this graph, which were presented at ASH 2 years ago, 44 patients were enrolled in this combination. Again, relapsed refractory patients with difficult to treat disease, many patients having received several lines of therapy, many patients being refractory, a quarter of the patients with POD24. The majority of patients were wild type for EZH2, but a significant proportion were also mutated. If we look at the safety, again, we observed that this treatment was well tolerated. There were essentially grade 1-2 events, which are common in patients with relapsed disease in clinical trial, but were also, for some of them, those that you will see when you use R-square, such as pruritus, eventually cough, eventually some rash, which you encounter with R-square, and other GI symptoms. There were also a little bit more hematological toxicity than in a single agent of tazemetostat, including some neutropenia that needed standard intervention. There were no prophylactic GCSF. If we look at patients with dose modification, the vast majority of patients has dose modification of one of these drugs, 63% for tazemetostat, interruption, but only 13% of the patient actually discontinued tazemetostat. Actually, the same proportion that discontinued other drug eventually because of treatment failure or severe side effect. Looking at the result overall, what was interesting to see is that the overall response rate, as you can see, was remarkable of 97.6%. 40 of 41 evaluable patients had a response to this therapy, and the complete response rate of this combination was 51%. So I think this result with partial response 19%, one patient with stable disease, suggests that there is a synergy between this R-square regimen. I remember you in Augment, we were at lower overall response rate, 60, 70%, a CR rate of 30%, and obviously higher than the one you see with tazemetostat, again suggesting a good synergy between these two drugs. The time of median progression-free survival, median duration of response was not reached. And in this first publication, as you can see, the 12 months progression-free survival was of 84.8%, something quite remarkable for follicular lymphoma heavily pretreated. And the majority of patients were still on therapy. If we look at the efficacy according to the presence or absence of the EZH2 mutation, as you can see, there were no difference or very few difference in the efficacy. Maybe a little bit more patient with a complete response in those that had the mutation of EZH2. But again, an overall response rate was similar and not much more patient with stable disease or not responding. If we look at the median PFS and the Kaplan-Meier curve for PFS, according to the EZH2 mutation status, you can easily see that there are no overall difference between these two curves. So patients are still on treatment. The results are analyzed. I hope they will be submitted soon for full publications to hear more about the prolonged follow-up of this patient. So again, obviously, we combine different treatments. There is some treatment emergent adverse event. Most of them are either the one you encounter with R-square, neutropenia, fatigue. There was some arthralgia also, some GI symptoms, or thrombocytopenia. But the majority of grade 1, 2 were reversible and manageable. And based on this data, the study now is open for accrual as a randomized study with patients receiving either R-square or R-square plus tazemetostat. This is the second part of the Symphony study. This is the schema of now the phase 3 randomized study assessing tazemetostat plus R-square versus placebo plus R-square, which is a continuation of the phase 1b portion that I presented with TAZ and R-square. If we look at studies in this field, there are other trials being done with tazemetostat combined with different agents, with rituximab, with multi-agent settings. Interesting data also suggesting a possible synergy with bispecific antibodies and other combinations being currently assessed in clinical trial. Tazemetostat not the single EZH2 inhibitor, and there are other drugs being in development or having been assessed as development. Some inhibitors are mentioned here with a few patients treated. This one was developed in China with a substantial number of patients treated and very similar result to the one we have seen with tazemetostat, other under investigation. What I will discuss briefly in the last part of this presentation is the activity of another drug, which is called valemetostat, which is an EZH1 and EZH2 inhibitor, which has given early signal of activity in B-cell lymphoma, including follicular lymphoma, which might be again independent of EZH2 mutation. But this drug is further developed in patients with T-cell lymphoma, peripheral T-cell lymphoma, angioimmunoblastic T-cell, or HTLV1 associated lymphoma. The study that led to evaluate the activity of valemetostat in patients with relapsed or refractory peripheral T-cell lymphoma is called the Valentine study and was presented at the American Society of Hematology by my colleague Dr. Horvitz last year. Very briefly, in peripheral T-cell lymphoma, there are also a role for the PRC2 complex, for EZH2. There are sometimes mutation of EZH2, but again, there are many active chromatin states that can be modified by adding this EZH1 and EZH2 inhibitor in the cells. Based on this rationale, there was a trial assessing a single agent valemetostat in patients with relapse or refractory T-cell lymphoma. This is the evaluation of this patient. On the left, you have the evaluation based on CT scan. On the right, based on PET-CT. There is a discussion what's the best evaluation for patients with T-cell lymphoma. As you can see on the left, the overall response rate was 43.7%, with 14.3% achieving a complete response. If you look on the right, it's a higher overall response rate, and it's a higher complete metabolic response. If you have treated patients with peripheral T-cell lymphoma and relapse, I think achieving a response rate in the range of 50% or more, with 1/4 of the patient achieving a complete response, is quite remarkable. And these data are important and led to consider the drug for approval. There are some treatment-emergent adverse events with a little bit more substantial hematologic toxicity here with valemetostat that you have seen with EZH2 only inhibitors, including thrombocytopenia, anemia, some GI symptoms, some neutropenia. As you can see, about 1/4 of the patient had grade 3-4, either thrombocytopenia, anemia, or neutropenia, but these events were reversible. There were 2 patients that developed secondary malignant disease. There is one side effect that clinicians need to be informed, because they need to inform the patients, which is the risk of alopecia in women. I haven't seen alopecia in men receiving valemetostat. For whatever reason, it occurs in women. And obviously, you have to discuss that with the patient, because you don't want to be facing this question after 2 months of treatment, not having addressed that. And it's reversible, but just to mention. The duration of response is shown on this slide. And as you can see, the median time to response was 8 weeks, but the median duration of response was almost 1 year. Again, quite a remarkable result for this patient with peripheral T-cell lymphoma and relapse. So to conclude this presentation regarding different drugs targeting the epigenetic and this emerging field, we have clearly a role for targeting epigenetic mutation in lymphoma. I will say it even represents probably a holy grail. We have to balance the efficacy and toxicity of this agent. Do we have more specific agents that target one enzyme, such as EZH2 or EZH1, EZH2, or other epigenetic modifier that are present in development? And there are obviously prospects of combination of therapy. So I think these developments are promising. We have already one drug approved. There may be other in the future, and there are ongoing studies to further assess the role of these molecules, either as single agent or in combination in patients with different lymphoid malignancies. I thank you for your attention today.